موضوع مهم وشاق، الأنتي كوغولنت. 10 دقائق يا نور الدين، ولو احنا نحبك لكن 10 دقائق.
صبحكم الله بالخير جميعا وهنيئا لكم الفطور. أنا ما أدري كيف أخلص دكتور علي، هم كانوا المفروض يطلعوا الجنرال السيرجن مش في الجلسة هذه، في جلسة ثانية. So it is my pleasure to stay in front of you to talk about the story of anticoagulants. وهي الموضوع صعب جدا في 10 دقائق، لكن أرعوني سمعكم يرعاكم الله. I'm going to concentrate on the drugs, so how, when, where to be used. That is a long story. I have nothing to disclose regarding to this talk. It's a matter of sharing you وأتمنى لكم التوفيق في المؤتمر. So I'm going to talk a brief introduction, the history, why NOAC, why we still use warfarin, what are the doses, how we can monitor these things, and then what's the final remarks. So who is going to listen to me? So the person who is going to listen to me, a person is cardiologists, electrophysiologists, physicians, or neurophysicians. And why they are this in particular, these people, they are listening to me because of the indications of anticoagulants in atrial fibrillations, in cardiac interventions, in thromboembolic phenomena, or even in the stroke. So why we are thinking of it? So we are thinking of anticoagulants because the dilemma of coagulations which is occur either because of local inflammations, systemic inflammations or factors, or there is local factors and local exposures make the patients get coagulations. So the coagulations cascade, I think all of you know, the end result, it is thrombus by the platelet actions, by clotting factors actions, or by the complement activations factors. So the antithrombotic drugs, they are either to prevent thrombosis like anticoagulants and antiplatelets, or even gas vasodilatations like nitrates and calcium channel blockers, or removing of thrombus because of thrombolysis and angioplasty. This is the categories where we are going to use anticoagulants. So this, all the antithrombotic drugs like these, antiplatelets, anticoagulant, thrombolytic, or even that herbal medicines, which you know. So I'm going to talk only in particular to this one of these antithrombotic drugs. So just simply, you know them, you keep in your mind that they are heparins and its derivatives, the vitamin K antagonists, or the direct oral anticoagulants, the DOAC, which is not nowadays, is NOAC. So if I ask any one of you simple questions, did you expect that, or do you know what's the warfarin? كم واحد يعرف ما هو الورفرين? If I told you that the warfarin is سم الفيران, you expect like that, والعلاج اللي بيستخدم سم الفيران. But this is just the things is like that. So what's the story? The story of anticoagulants, يمكن لو شفتم بس these papers when it is just published in 1949. So they said, is there something we can do it beyond that, use anticoagulants heparin and eucomarons, warfarin? هل في شيء جديد ممكن نعمله? The answer, they find it yes. Well, the story is coming يمكن بدأت من medical students who discovered the heparin, and it is going on. So why the story is going on like that? So they said this heparin, it is used IV. We need some drugs not to use IV. They think of warfarin. So warfarin, it is long-acting drugs. We need the drugs which is working IV in short-acting better than warfarin. Then they think of local low molecular weight heparin. So they think we need some drugs to work like low molecular weight heparin in short actings, so they think of the DOACs or NOACs like that. And then the stories is coming by the years is like this. So just recently they think of the DOAC or NOAC in 2010. So they start to use it in the era of medicines is like that. And many studies, they prove this, the drugs which is used the relay study or other studies, the Libixan studies or rifaroxaban studies or edoxaban, كلهم they are studied, they prove to use these drugs. They think, what's the mechanism of actions to be acting nicely in such drugs? We select the drugs better to be worse in single site. When direct actions, it will be better. So this is just the dilemma when we are in a medical student era. كلنا يمكن كنا خايفين من الكاسكيدز of coagulations, the extrinsic وintrinsic pathway والcommon pathway, والأمر فيهم هم بالأعداد ممكن تحسب سهلة 7 زائد 3 10 12 11 9 10 2 1. That is just simple things if you keep it in mathematical way. And the actions of warfarin ويمكن كنا نحفظه كثير في 1972 الانكسبارين والهيبارينز they work on all intrinsic factors pathways beside the factor 10 and factor 2. المجموعة النواكس الجديد كلها بتشتغل على الفاكتور 10 except the dibigatran is worse in factor 2. والسؤال اللي يمكن بس سألته بعض الطلاب في حق الام دي why you are not using in this way؟ ليش ما اكتشفوا علاج يستخدم على الفايبرين or factor 1؟ Keep it in your mind if you know the answers. So this is just the mechanism of different anticoagulants. So why we are thinking of NOACs? We are thinking of NOACs because the warfarin is narrow window of range, routine coagulations monitoring. We have frequent doses adjustment, so it is just a slow onset of actions, numerous food drugs interactions, numerous drugs interactions, risk of bleeding with warfarin is more. And they find that the death of coagulations is common with warfarin rather than other drugs, and 6% of patients they hospitalize and they find in emergency situations because of warfarin. If you say it like that, warfarin compared to other different medications, warfarin it is considered to be the #1 emergency drugs follow-up and complications. So this is the other side effect of warfarin. Almost all of you know it: hemorrhage, embryopathy, necrosis, osteoporosis, or Berbel hand syndrome. So again, the questions coming to the mind, we don't want this side effect, we don't want such complications, so we have to think of NOACs or DOACs. So if we see all the studies is like that, really, rockets, artists, angels combined, كلهم they prefer to use the NOAC rather than warfarin in the new era of anticoagulants. So even if you see this comparison between the warfarin and the DOACs or NOACs, كل الأشياء يمكن they are going better with NOAC rather than warfarin. They start to use NOACs more. So this is the things that the new oral anticoagulants, rapid, fixed, no food interactions, what is less, well, monitoring, we don't need it, well, offset is short. So if all of these adjective things, the proper things and good things for the NOACs or DOACs, why we still use warfarin? وليش ما زلنا نستخدم الwarfarin? So we are still using warfarin because we are familiar. We are already expert in it. We see a lot of complications, already familiar with complications. So we can see, so the followed patients, there is some patients you cannot use the DOACs like all the young, pregnant, lactating, antiphospholipid antibody syndrome. So the other things, the patients, they prefer to use warfarin, and patients concerned about the cost and the therapeutic range more with warfarin. The bleeding in GIT is less with warfarin. Patients with thrombosis still till now, either intraatrial thrombus or interventricular thrombus, the uses of DOAC is less evidence to be used. We know also the pharmacodynamics, pharmacokinetics of warfarin better than the others. So DOACs is not used in pregnancy and breastfeedings under the age of 18 years. We are not use it. Sometimes they said in limb ischemia we are going to use it, but nowadays I think it used, we still to use it. The other questions, what are the doses of these DOACs? Simply, we should concern about the patient's adherence. We should know how to use the doses with foods or without food. Which patients in particular we are going to use the DOACs or not? These patients, reductions of risk of stroke and systemic embolizations in non-valvular AF, prophylaxis in DVT, prophylaxis or treatment of DVT, especially in the non-cardiac surgery. And instead of using injections, So the NOACs or DOACs replace these things, treatment of DVT or pulmonary embolism, reductions of recurrent thromboembolic phenomena, and now it is entered in the coronary artery disease or peripheral artery disease. How to use it? The matter of to use it, it is a matter of balance. The balance between the risk of bleeding and the hemorrhage. So we had the SHAD score, يمكن ده شالوا الاس منه الآن, وهاز بليز score, وكل واحد فيهم أي كاس to use which balance I use in these things and to use in patients. Simply the doses of NOACs and DOACs, يمكن الدي قطران least use, which is the dose 150 BD, 110 when we are using low dose, rifaroxaban from 2.5 up to 20, Ebixban 2.5 up to 10, Edoxaban 60, 32 up to 60. It depends on the renal and the patient's uses and the treatment where you are going to use it. In surgery, especially non-cardiac surgery patients, يمكن هذا السكيم كلكم حافظينه in guidelines. لكن simply how I can use this scheme, so it depends on the mechanism of actions.
It depends the time.
Okay. Yeah, I guess you use it in different things of prophylaxis in non-cardiac surgery. Monitoring, there is no monitoring used in NOACs, like we should just keep in the patient's follow-up and how to use it. Well, keep in your mind the has-bleed score, well, other things of use it. To switching between anticoagulants, it could be switched to different type, like when you are going to switches in proper patients where the patient is not contraindication to use these anticoagulants. The other things which I'm going to tell you, just I give you some cases, just kindly, معلش, give me a minute. So these are the patients where we are going to use. If you have different ways to use this anticoagulant, simply I will give you examples. If there is normal patient with thrombosis, normal liver function, normal refer functions, which one is used in these things? So all anticoagulants could be used in these things. So we prefer DOACs in such patients. Patients with renal impairment, which one is better? Unfractionated heparin, warfarin. Patients with hepatic, heparin, low molecular weight, warfarin. Patients with cancers, low molecular weight, heparin. Child, warfarin, and other. Pregnancy, heparin, we can use warfarin sometimes. Lactations, warfarin, heparins. Risk of bleeding, all could be used except the NOACs, ما عدا الإبكسبام. Difficult to monitor, use low molecular weight, heparin, and DOACs. I think I'm going to finish, Dr. Ali, so I'll give you the final message in these things, what it will be. So the final message, warfarin is a powerful anticoagulant, has the best evidence based on anticoagulants use, but the side effects and complications is more. NOACs, it is easy to use, prescribe and monitors, efficacy of specific group, yet sometimes need more studies in renal, hepatic, mechanical valves. I'm finished.
14 دقيقة قد معك. والله نحن نحبك والعلم مليان.
الله يحفظك بس
العلم مليان ما شاء الله.
مرة ثانية مع طلع الدكتور علي هنا.
أنا أحبه
الله يحفظك. أحبك. وشكرا لك.